So hello everyone, we are here today with Dr. Sasha Blaskovich, who is a doctor based in Vancouver, Canada. And today we're going to be talking about Atlantoaxial instability and going into the depth of what the condition is, how it's extremely underdiagnosed, and how there's a lot of work to be done. So this is Dr. Sasha.
Thanks for having me, Ravshaan. It's nice to be here.
All right, so we'll get straight into, I have a list of some concerns and questions that I had when I was a patient. So what we'll do is we'll get straight into the questions so that anyone who's going through a similar sort of struggle knows exactly what to do. So Dr. Sasha, I know a lot of people present to you with Atlantoaxial instability. What are the common symptoms that you, witness on a day-to-day basis of Atlantoaxial instability?
Sure. I knew you were going to ask me that question, so I came prepared. I actually have an Atlantoaxial instability questionnaire that I have, and it's not all inclusive. And it's a work in progress because oftentimes people come with additional things that when I look them up, they're definitely linked to brainstem related compressive phenomena that could be causing different neurological manifestations. But I'll read the list off to you here that basically is on this questionnaire that I have. And so it starts with just the regular symptoms that people present with that they oftentimes consider symptoms related to their problem. And then it gets into symptoms that most often the patients don't recognize or even linked to their Atlantoaxial instability. And moreover, a lot of their doctors don't even consider being linked to their instability because they don't even ask about them. So to start, we have occipital headaches, so headaches at the back of the head. Migraine headaches get diagnosed as migraine headaches, neck, shoulder, and jaw pain, difficulty swallowing or a sensation of being choked, hoarseness in their voice or frequently having to clear their throat, runny nose or sinus, persistent post-nasal drip, like there's always some mucus flowing into the back of their throat, tenderness at the base of the skull, so that's similar to the occipital headaches, feeling like they're bobble-headed, like their head isn't attached to their spine, sensitivity to light, so photophobia. And then we have blurry or double vision. We have ringing in the ears or phonophobia even, which is sensitivity to sound. Feeling like their ears are plugged, like they're going up in an airplane and their head is, or their ears are pressurizing. A whooshing sound in their ears, and we would refer to that as pulsatile tinnitus. So you can actually hear the whooshing in your ear. Tremors, hot flashes, cold shivers, heartburn or acid reflux problems, diarrhea, constipation, increased urgency to urinate even when they're not hydrated, orthostatic intolerance, they prefer to be lying down, dizziness, vertigo, heart palpitations, blood pressure issues, shortness of breath, nausea, fatigue, excessive sweating, irritability, or they're quickly angered, difficulty concentrating, electric shocks randomly throughout their body, cognitive memory decline, so short-term memory, clumsiness and other motor difficulties, such as difficulty doing up zippers or difficulty putting up buttons, feeling like they're coming down with a severe flu, but it never actually becomes a flu. It's very short-lived, fainting, and weakness in the limbs. So that's just, like I said, it's not an all-inclusive list, but it's some of the more common things that people mention and more common things that people admit to having when I ask them about it.
Wow, that is a pretty long list, to be very honest. There's not a lot of conditions which have a symptom list that goes that long.
True.
So again, a lot of these symptoms were what I experienced personally. Not all of them, but the most major concern for me was, as you mentioned, weakness was a big issue in terms of there was two kinds of weakness. One was in my arms and legs, that physical weakness, and secondly, also not being able to get out of bed easily. I wanted to go back to sleep all the time, and even if I slept for 12, 13 hours, I was always, in a couple of hours when I woke up, I was again back to being extremely exhausted and basically wanted to go back to bed. And then memory was something that I brain fog was a big issue for that. Personally, dealt a blow to my confidence, uh, and that I think affected my mental health as well, because I was concerned that because of not being able to think or concentrate properly, I was not being able to I would not be able to accomplish much in the future. But hopefully, anyone who's going through this, if you're thinking that your future is there's nothing left, just stick through it, be strong, and one day, there's definitely a light at the end of the tunnel. So,
Yeah, and I think as a
and
side note for people who are watching to see
right,
you and you're commenting on how you had all these things, I think your relevant history is that you had those things, and in your case, it ended up resulting in the necessity for fusion surgery of your upper cervical spine, which then took the pressure off of your brainstem. And then when you're relating to the weakness in your limbs and the weakness in your total body, when your central nervous system is being compressed, your central nervous system governs the tone or the resting tension of all the muscles in your body. So if it's constantly being bombarded with pressure, it's going to be basically on override. And so the ability to then utilize your body for energy and power, which is not a central nervous system event, your central nervous system only governs the tone of those muscles, and the actual activity of those muscles is done by peripheral nerves. But because the central nervous system has put your entire muscular system on a high level of tone, that then when you demand or require for it to be utilized with your peripheral nerves, it's already in a weakened state because it's already partially exhausted. And that requires for you to then lie down and rest. And so I think, like I said, it's relevant, I think, for people to know that, your fix, if you will, or your improvement came as the result of a fusion surgery. And that, like I was telling you before we got on here, that your range of motion, I would, if I didn't know better, I wouldn't think that you actually had surgery. So that's wonderful to see the ability of motion that you've maintained.
working on range of motion, a bit, and this is what I have. Up and down is almost completely normal, but to the sides is slightly restricted.
And you'd
But again,
expect that, and you would expect that, but yeah.
compensate that,
So you do Stevie Wonder exercises with your head.
Yeah. All right. So the second question that I had for you was again how these symptoms, this huge list of symptoms, can be caused by something that is just in one place. How can this is something that I think doctors also struggle to get there. Doctors who are not aware of what's going on, they also struggle to put two and two together and see how so many symptoms can be caused by something that's just right here.
Yes. I guess the simple answer to that would be to, Google responsibility of the vagus nerve. And so vagus nerve is your 10th cranial nerve. It's an autonomic nerve that is sensory and motor. And the capacity or the outreach that your vagus nerve has is very wide reaching, if not pretty much the whole body, a large proportion of the body for autonomic or automatic functioning of different organ systems that are, linked to sweat, linked to heart rate, blood pressure, temperature control, digestion, blood vessel diameter, all those phenomena that are global and body wide. They're a large percentage of their governance comes from the vagus nerve, and the vagus nerve just happens to branch off of the brainstem roughly at the level of C1, C2, where we have the atlantoaxial problem of AAI. And so where the vagus nerve branches off of the medulla oblongata, if you have compressive forces in that region, it can logically enough affect any of those systems. And why it affects the heart palpitations in one person and then balance and coordination in another, at least more evidently at certain times. That is something that I haven't quite been able to put my finger on, and I think there's probably an answer out there that I'm gonna searching for, but why it manifests differently on different people, why some people have more issues with heart palpitations, other people have more issues with being orthostatic or upright, other people have issues with digestion, diarrhea, constipation, and others have blurry vision, fullness in their ears. I've even seen patients that when they go underwater, their ears actually bubble, and they've been inquiring about that for months and months and months with all their practitioners, and everybody dismisses it as, oh, that doesn't exist, you're imagining it. And when I've seen these patients actually film themselves in a bathtub, and you can actually see bubbles coming out of their ears when they repressurize, it has a very wide-reaching effect on the entire body. And the reason is that small little region is the region that just so happens to be the region that is supposed to protect the brainstem and spinal cord. But unfortunately, when you damage ligaments and it becomes unstable, it also becomes the thing that actually causes the problem. So the number one job of our skull and our spinal canal is not for movement, it's to protect the central computer. And so once that movement becomes excessive, that extra movement has the capacity to now encumber upon the thing it's protecting. And when it starts to encumber upon the thing that it's protecting governs all bodily function, if you will, or a lot of the bodily function. So, and any nervous structure, when pressure is elicited upon it, it will emit a spontaneous electrical signal. And that electrical signal, wherever it ends up, will cause an effect. So if that electrical signal is going to go to the heart and its job is to elevate the heart rate, or if it goes to the sweat glands and it's supposed to cause sweat, that's exactly what's going to happen. Or if it makes the stomach release acid, it's going to release acid. So it'll release acid without the presence of food. It will cause the heart rate to increase without any exercise happening. So these will be all phenomena that don't really match the circumstances or the situation. It'll happen what would appear as random, and it's random in the sense that there's nothing that's precipitating it. So then the search ends up being directed or focused on the organ being the one that's doing something wrong, versus that the control of that organ from a central location is being somehow altered to create that signal at a time when it's not supposed to be created.
That's a wonderful explanation. I have to admit that I've spoken to so many doctors and even neurosurgeons, and nobody has ever explained, the cause so well. So that was a wonderful explanation, doctor. Also, another thing that I found from my research was that blood flow might be compromised to the brain as well, and CSF drainage. Are those two also potential contributors to symptoms? So blood flow, yeah.
Yes. So again, all linking back to AAI. So when you have atlantoaxial instability, you're susceptible to what chiropractors call a subluxation. So something will not be aligned properly, and that malalignment will result in the overall diameter of your canal that houses the brainstem and the spinal cord at the junction point between C1 and C2 to be narrowed. So normally, if I can show this, you're supposed to have two rings that superimpose each other. So two rings like that. And then when you have instability, those rings can go off center, and you can see how the part in between here gets narrower. And what goes through that part in between is the brainstem at the junction where we have the vagus nerve and the other three cranial nerves that come off of there being impinged upon by this. So that's part one. You have direct mechanical compression from the AAI. Through that region also, you have the vertebral arteries coming up vertically and then angling in at C1 and then going up into the brain. So when you alter the positioning of the vertebrae, you can put tension on one of those vertebral arteries. And when you put tension on it, the inside of the vertebral artery also narrows a little bit, restricting the volume and pressure the volume of flow going through there. So it will cause a hypoxic reaction upstream from there, or downstream, I guess. And the other thing is that the inside of the actual brainstem has a drainage tube. And so when you have this phenomenon happening, not only do you put mechanical compression on the actual neurology, which emits spontaneous electrical signals, but the brain itself is making CSF based on the heart rate. So when your heart shunts blood through your system, the blood also hits up against something called the blood-brain barrier, which is basically a cheesecloth that surrounds your entire brain. And across that blood-brain barrier, only plasma or fluid can get across there, and your blood cells bounce up against there and then keep circulating. But the plasma that gets shunted across, so the higher your heart rate is, the higher your blood pressure is, more plasma gets shunted across that blood-brain barrier. So then inside your brain, your ventricles actually make more CSF with the raw materials that they've gotten. and then they have to release more CSF into the brain circulation and the neurological circulation. Now that extra CSF also has to drain through this region at a normal rate. So it has to drain at a level just equal to how much is being made. And then when you have this phenomenon, you're also narrowing that canal on the inside that is the drainage tube for the CSF. So then CSF is being created in a larger volume than is being drained. And so then it has to back up into your skull. So it backs up into the skull. And what generally then ends up happening, and you see this subtle manifestation of this on people's MRIs, is that their ventricles will actually distend, and they'll actually traverse, the horns will traverse further to the back and further to the front of their brain instead of really central. And then when that happens, you'll see what looks like subtle accumulation of fluid in and around their actual brain. So what I think happens is that some of the CSF seeps out into the actual, out of the brain under the skull, and actually starts to compress the brain back downward. And this is also where you see, I think a lot of people end up having what's called cerebellar tonsillar ectopia. So their actual cerebellum distends down a little bit into the foramen magnum and occupies the space that only the medulla is supposed to occupy. So now you're having this phenomenon happening. You're having the medulla in there compressed, and you're having the cerebellum drop down, also providing pressure on the medulla, and the medulla providing pressure on the cerebellum. So you get this whole gamut of symptoms. And this is why when a person goes and lies down, their heart rate drops, their blood pressure drops, the CSF production starts to become more equal to the CSF drainage, and they feel better after a while.
Right. Makes a lot of sense. Makes a lot of sense. That was a great explanation. So now let's come to someone who's suffering, a patient who's, possibly having all these symptoms. They want to know, they've been to so many doctors, they've been to neurosurgeons, neurologists, and they're not getting answers. So they want to know, they're not even getting an answer as to what the diagnosis is, forget about treatment. So doctor, how do we, what's the best method for a diagnosis of this condition?
My opinion is that the best method to get a diagnosis of instability has to come by way of functional imaging. So whether it's putting a person's head and neck into a stress position and then doing MRI sequencing, so whether they're flexed and then they do an MRI with them flexed, whether they're rotated and they do the MRI or CT scan in those stress positions, or the more easy and real-time evident method of doing this is motion X-ray. So real-time fluoroscopy, where you can actually watch the movement through the entirety of the range and see what's happening, so that you can actually track and say that part is moving excessively compared to its counterpart, for example, on the other side, or compared to the counterparts that we know are asymptomatic on different patients. And so what I do myself in both Langley and in my US clinic is I have a motion X-ray machine, which is basically a fluoroscopy C-arm. And I get the patients to go through all three cardinal ranges of motion, so front, back, side to side rotation and combinations of those. And then we watch on the video screen real time what's happening between the bones in their neck and then the skull, how it relates to the upper part of the neck. And then based on the findings of that, we can also quantify how much movement there is. And really, compared to what's expected, there should be really no measurable translatory movement at C1 and C2. And when we find whatever the quantification of that is, we can say you have instability. And the reason that we can say that you have that is we've actually watched it. We haven't speculated. We've literally seen it happen. And I get this question, posed to me a lot by medical practitioners, is that, well, aren't you supposed to have motion there? Isn't, the motion there expected and normal? And so what I have done for that particular purpose is I've compiled a whole slew of videos from patients that we've done over the years where they have a unilateral, so a one-sided overhang. So the biggest thing to look for is the overhang where C1 on C2 slides sideways. So they're supposed to line up vertically. And when they bend their head to the side, if C1 shifts sideways off of C2 partially, that indicates that the ligaments on the opposite side have been damaged, resulting in the instability. So if this was normal, we would also expect to see that on the other side when they went the other way. And we often see that. So then the question is, well, is that
right.
normal or is that abnormal? But then when we have patients that, for example, have been hit from the side in an automobile collision, so they've been T-boned, and then we do the imaging on them, and then when they bend their head one way, we see this overhang, and then when they go the other way, it goes as a single unit. And so then my question then to the medical practitioners that raise this question, and it is a good question to raise, especially when you don't have the experience and having seen thousands of these scans like I have. I think it's a credible question to ask, but then I would ask then, is this normal or is this normal? One of them has to be abnormal. And based on my observation of patients who have severe symptoms, when they have this, they have those severe symptoms. When they have this, they do not. And so I would, humbly say that this would be the expected or the normal, and this is absolutely abnormal and injured.
Understood. So you said again, the digital motion X-ray and MRIs in
stress positions.
And
the problem with that is it seems like that would be logical because you can see soft tissue, you can see the spinal cord, you can see the brainstem, you can see CSF. The biggest problem with this is that it's virtually impossible to find a facility that's willing to accommodate this. So especially within the public hospital system, they're just not willing to do this. And their reasoning for that is they say that their coils don't have the ability to engage in that type of non-neutral positioning. And they do, because I mean, the stuff that I've seen from places like Germany and Iran and Sweden and different countries, it's very possible to do it. But I think where the dilemma or the problem comes in is that when it's done, it has to be reported on. And there's no training available, I don't think, that at least any of the Canadian board certified radiologists that I've encountered have in being able to actually assess that and put their signature to it as an expert. And so I think where the limitation comes from is not that they can't do that stress positioning, it's that they don't have anybody on staff that can actually report and sign off on that as an expert. And so then by default, they prefer not to do it so that they don't have the liability of missing something. Whereas with the motion X-ray, I'd conduct it myself. I calibrate the measuring tool myself. I calibrate the software myself to make the measurements, and then I actually do the reporting myself. So it's all in-house, and there's not 6 different people doing the same single task to get an end result. And so that makes it a lot more streamlined. And there's less of a chance of something being either missed or not paid attention to, because it's all done within the same concept, if you will. But no matter how you slice it, the bottom line is it either has to be stressed or functional in real time. There's no way to look at a neutral anatomic position, and unless there's a fracture or dislocation or severe arthritis, there's no way to tell how that functions. And this issue is an actual issue of aberrant function as opposed to bony anomalies.
Right. So my diagnosis came from again, as you said, a stressed position. So it was a CT rotation that revealed my diagnosis. Does that work as well? A CT rotation and a CT angiogram? Because
I mentioned that. Yes. So the CT rotation, yes, and so a CT angiogram in stress rotation is even better, because then you're seeing how that rotational position affects vasculature as well. Like you asked before, how does this affect vasculature and blood vessels? And so when you put someone in a stress position, say they have instability, it will actually, like I said, stretch that vertebral or one of the arteries. I'm using the vertebral artery as just an example, but it would actually put tension on that, and the tension causes a narrowing inside. So you can see that, compare left to right, or compare both if they're both deemed to be, not within the normal range to what would be considered normal. And then say there are compressive forces and stenotic forces happening here as a result of this excessive tension from the instability.
Right.
Now, so just to clarify before I let you, so this is the hot topic that I could talk about for hours, but with neutral standard anatomic imaging, whether it's a CT scan or an MRI or just a regular X-ray, oftentimes, I would probably say 80% of the time, there are subtle hints on the static neutral, like the usual imaging that they make, that tip me off to think that there's likely instability here and likely ligament damage here. And I come across this quite often when patients from all over the world send me their imaging to look at, where they say that my imaging was completely normal according to the reports or unremarkable. But then when I see the imaging, I see these little subtleties that tip me off as to the notion of this person, especially based on the symptoms they're telling me that they have, has ligamentous compromise resulting in instability. And so I think that even when imaging is done in neutral, if someone is being told that it's all normal and there's nothing to see and it's all unremarkable, it would still behoove them to get a second opinion on that already created imaging to see if there are any subtleties or hints that would tip one off to say there is a suspicion here of instability.
Right. So now that we've spoken about diagnosis, I think it's time for us to talk about, now that someone has their diagnosis, they know it's Atlantoaxial instability. What do we do about it? What's the best treatment that we can do to fix the issue?
That's a loaded question because there really is no one magic pill for this. It's a daily way of life treatment regimen that involves self-empowerment, but also some passive form of therapy, and that would generally fall into the category of non-forceful manipulation of tissue that does not involve any high velocity, high impact techniques. So something that is a very low impact technique, like you were mentioning NUCA for yourself, that's a really good one, upper cervical chiropractic care. I think massage therapy, but then trigger point therapy. So not motion muscle work, but acupressure muscle work, which is what I do to myself.
Right.
I find that to be the most relieving of my symptoms. And then diet, mindfulness, hydration, proper rest, reduction in stress. I mean, there's a whole gamut of things that are valuable for people living with AAI that don't necessarily, and they don't actually fix the AAI, but they mitigate to some level the cascade of systems that the AAI affects negatively in a positive way. And so it's literally all day long and multiple times hitting some kind of a temporary reset to maintain some level of status quo so that you don't get a flare up. But there really is nothing magical that can take, the baseline level of symptoms that most AAI people have and actually get rid of it. The only thing that I've seen actually do that is fusion surgery. But again, not everybody should go for fusion surgery, but there are also people that have gone for fusion surgery where they didn't have that. They actually continued to have symptoms, and some of them even got worse. And so there is no magical answer to the phenomenon of, what do you do to treat yourself? And again, as far as the surgery is concerned, there are many surgeons around the world that are willing to address this. A small handful that are really experienced in doing this. And so it's really not everybody's surgery is going to be, the magic bullet, and not everybody's surgery is going to make you worse. So it's really, every case is different and needs to be assessed in a very unique way to determine which particular neurosurgeon would be best suited for this. But when a person's trying to address treating themselves, like I said, there's a whole gamut of things, and it's hard, and it would be virtually impossible as far as time consumption to get into all of those things right now. So I guess the only thing that I can say, and I'm not trying to self-promote my book, but I wrote a book that basically the whole intent of that is to actually empower people to self-treat. So from all the different aspects, from wellness, from mindfulness to using ice, hydration, trigger pointing oneself, you name it. It's called Dr. B's Concussion Breakthrough. And if you just, if a person were to want to look into it, there's an audio version, because I can't do real books. With my AAI, I have to do audio. That's the only way I can register the information. If I read a paper book, I keep rereading the same line and I don't get anything out of it. Whereas when I close my eyes and I listen to audio, I take away the stimulus of my vision, and the audio really embeds itself into my brain and I can retain a lot of it. And so I wanted to make sure that it was available in audio for specifically for AAI people who don't have that visual concentration capacity that also helps them register the information to make it useful. But yeah, if anybody's interested in that, they can just literally go onto Amazon wherever they are and just type in my name, Sasha Blaskovich, and it'll pop up there. And like I said, there's an audio and a paper version of it. But that sort of goes through all of the things that I've done myself to mitigate on a daily basis the issues that, you know, because I live with AAI, as you and I have discussed prior to the video here.
Right.
But all the things that I've done myself on a daily basis, and oftentimes multiple times a day, to keep myself at hopefully a level keel. And then my co-author, he's had, you know, 15 or something like that concussions, and he's done some other things in addition to the things that I've done to help him mitigate his daily symptoms that he's lived with for, you know, quite a while now too. So the intent of the thing was to basically provide a guideline or a handbook for anybody who's dealing with this kind of stuff, to be able to be empowered to put that into their own hands as much as possible each and every day. And the reason that the book is called Concussion Breakthrough is because a lot of patients get diagnosed with a concussion or post-concussive syndrome, but the actual problem is at the C1, C2 area. And so the breakthrough is that the C1, C2 area, as I explained to you, with the CSF drainage being blocked and the brainstem being compressed, those are all neurological structures that, when irritated or compressed, equate to the same symptom pattern as concussion does or post-concussive syndrome does. And so I believe that, you know, concussion and upper cervical whiplash, you can't separate them. You absolutely can't say it's just a head trauma or it's just an upper neck trauma. It's both. It's momentum. The head has to stop. The neck has to stop that momentum during the trauma. And so there's no way to have one not be influenced and the other one be exclusively influenced.
Right. Understood. So definitely, I think for someone who is going through symptoms, if it's not a complete emergency, everyone must, you know, try natural non-surgical options first, as you mentioned. I think the book will be a very helpful resource, especially the audio book, because I remember when I had AAI, you know, I didn't feel like reading because it was so demotivating to, you know, not understand. And again, as you mentioned, you know, reread, so that gets kind of demotivating. So the audiobook can be extremely helpful for someone who is going through this. And I would recommend that when you are listening to the audiobook, there's going to be a lot of information that is extremely helpful. So get a notebook, a pencil, and, you know, note down the things that you learn so that you implement those changes. Because if you just listen to the audiobook and you forget about it, that's not going to be helpful. So if you make a note, make a plan, you know, you see doctor talks about diet, so you take a note of that. This is the dietary changes that I have to make.
Yeah.
If you talk about sleep, then, you know, make a note. This is how I'm going to change my sleeping schedule. I'm going to start sleeping half an hour early every day, waking up half an hour earlier every day. And if you make a plan, I think, especially with manipulations, if you do manipulations and you do all the other complementary therapies, I think you can live a very, very normal life. Am I right? Without surgery?
Well, you can for the most part. And the other part of that is that even though it's, you know, a relatively normal life, when you have dependents, so a spouse and children, oftentimes you can do what you have to do, but they may not always understand the when you have to do what you have to do. And so it's really crucial also for anybody who has a spouse or children, at least children of an age that are acceptant to understanding what's going on with mom or dad or whoever's experiencing this, is to also inform themselves on this whole notion, because without the support of people around you understanding what you're going through, because for the most part, most of us externally look normal. So when we have a meltdown or we have a flare up in symptoms, it's unjustifiable for the people around us. At least in the long term, it becomes unjustifiable because they see this normal looking person that, you know, for the most part can function in a normal, fit, energetic way, but they have these moments where they get a setback, and the person who's not going through it, so the family member, can't comprehend how that's possible because they're not going through it. So to have them understand as well, by also engaging in this information makes it that much more useful for everyone involved, because if you do have a family, they are involved. So when you have a meltdown, they have to deal with the fact that you're going to go crawl in a hole into a dark space and recover for a little while before you come out, so that, you know, they're supporting you, as opposed to being the stress on the strain on your psyche by not understanding and even, you know, becoming, you know, verbally non-supportive of what you're going through. And so then that ends up causing a lot of problems. And so I think it's sometimes even more relevant for the other loved ones to understand this phenomenon than the person themselves, because the person themselves is living it every single day.
Right.
And I think when I tie back to your last question, is what can people do? So my co-author and I, we really pondered this, because we knew that embracing all that information is going to be overwhelming, because most of the people with AAI are already on a neurological overload. And so to start bombarding them with all this information that they then have to go make work of would be seen as relatively, you know, like a climbing Mount Everest. And so we had discussed quite a few times as to, is there one thing that we can do to provide a support to this outside of, for example, which already existed at the time, which was my trigger pointer device that I use on myself. It's a stick that I use to do trigger point pressure points on myself, which looks like this thing right here. So I designed this thing selfishly for myself so that I could go and work on my own neck and provide, you know, pressure points just in the middle of the day whenever I need to. And I'll hold a spot for 20 seconds. I'll move on to the next one, work for 20 seconds, and then I'll switch it around and do the other side, the same thing. And I don't really have to, you know, depend on a therapist to do this for me. So I will do that. But the thing that him and I came to the conclusion was, because most people are apt to trying supplements. A lot of people are taking extraneous amounts of different supplements to try to alter the chemistry of their system, because like I said to you before, the perception is that this is a chemistry-based issue and not a mechanical-based issue. And as you know, and as I know, and as a lot of people eventually find out, especially if they have a true AAI, is that the problem is mechanical-based. A vertebra shifts too much because it's not being held in the normal position. When it shifts too much, it mechanically compresses the brainstem, and you get this whole cascade of neurological symptoms. But what we designed was a supplement, a powder supplement that is intended for post-concussive issues. But like I said, AAI, especially post-injury AAI, is pretty much what the system defines as a concussion or post-concussive syndrome, because it affects the neurology. And so we formulated a supplement that's a powder supplement with 15 key ingredients that a person can just mix through water and drink. So there's no need for 30 pills a day. It's literally just one scoop. You mix it with water or smoothie or whatever you want to use to get it into your system. And so for myself personally, I've noticed that it does nothing for my pain level. So if I'm having a headache, it does nothing for that. It does nothing for my neck pain. But what it does do is it has phenomenally worked on my multitasking and my cognition. So my ability to have my short-term memory be better, which then helps me multitask and do several tasks at one time, and my energy level. When I don't take it, I'm not as good. And again, it doesn't fix my AAI, and it doesn't get rid of my headaches, and it doesn't get rid of my neck pain. But it has definitely, for me personally, shown an improvement in cognition when I take it. And so that's part of.
So it's a nutrient, right?
Yeah, it's a vitamin supplement, basically. Yeah, and it's called New Brain. So we creatively named it, but it's not spelled new. It's spelled NEUBRN. So new as in French, NEU, and then BRN for brain.
Right. So that's again a very critical point that you touched on is nutrition. So
yes.
Nutrition, you have to be taking nutritional powerhouses of food, because you're already in a compromised state, and you have to, the fuel that you're taking in has to be the best quality. And personally, I experienced this myself at around the 6 to 8 month mark. I came across, the plant-based diet, and I made the switch. I quit meat, I quit dairy, and I won't say that fixed my subluxation. It's not like, the physical problem was addressed by that. But again, the symptoms that I was experiencing, the weakness wasn't as bad. I had so much more energy. I didn't have to go to bed every 2 to 3 hours. I could last the entire day. My clarity and my sense of well-being was also boosted when I made the switch to a plant-based diet. And what I also noticed was I've spoken to so many Atlantoaxial instability patients, especially after I made the 2 videos. And a common theme I found in all of them is I spoke to a patient from Vancouver, I spoke to someone from Chicago, and someone living in Arizona, and all of them were on a plant-based diet. So it was pretty amazing to me, and I've genuinely felt that it actually makes a difference. And so, what's your take on that? What's the importance of a
Absolutely. It's actually in the book as well. So we highly endorse a plant-based diet to take out, you said meat, but to take out pretty much all animal protein. Animal protein
Right.
has an acidic breakdown, which is inflammatory. And so if you can mitigate as much of the inflammatory agents that you have normally been ingesting into your body and eliminate them from ingesting them and focus on the ones that are non-inflammatory, so the plant-based ones, then you can go a long way in improving your overall health, which may have not been that good to begin with prior to your AAI, but you just realize it more once you have your AAI. And a caveat, which we also again discuss in the book, is when you go to a plant-based diet, if you're not able to embrace an organic plant-based diet, you're left with ingesting probably more than when you were eating meat, but you're probably left to ingesting more pesticides, herbicides, and basically products that are intended to be poisonous. And so you have to turn your inorganic vegetables and produce into as good as organic or as close to as organic as you can. And so we get into that in the book where we actually talk about soaking, different things in apple cider vinegar and water for a while, which dissolves the pesticides. And so when you rinse that off afterwards, you're literally getting the fruit or the vegetable that you thought you were getting minus the pesticide. And even, we would even recommend that when you're actually eating organic, because you can never guarantee something's organic. For example, if something claims to be organic, but it's grown in a field where they have wood posts, well, those wood posts are treated. So that treatment material seeps into the ground and the earth water. And so you can't really, just because they're not sprayed, it doesn't mean they're not exposed to chemicals. Right? So you could be eating something that you think is organic, but it's grown in an area where the roots are soaking up water next to the posts that are treated. And the treatment of those posts makes them inorganic.
Right.
So, but yeah, so I'm a high proponent and supporter of a plant-based diet and removing as much as, if not all, animal protein. So that includes, like you said, dairy and cheese, everything, and just going to basically plants, seeds, nuts, oils, and sticking to basically the nut oils. So like, well, not nut oils, but the seed oils like olive.
So last question, Doctor. I've taken a lot of your time, and I really value that. So the last question I'm going to ask is, we were just talking about a plant-based diet. A lot of people have concerns about whether their protein intake will be met through a plant-based diet. But from the research I've done, I've listened to basically documentaries and videos and documents from a lot of plant-based doctors around the world, and they say lentils, beans, nuts, seeds are rich sources of protein. Is that, do you agree with that?
Yes, I do. That's very true in all plants. So whether they're fruits and or vegetables, they have protein in them. Even though the focus is always on complex carbohydrates in fruits and in certain vegetables, there's also a lot of protein in there. And it's not just beans and peas and things like that and lentils. So most spinach, broccoli, cauliflower, they all have protein in them. It doesn't get discussed because people talk a lot about fiber and about different things, in vegetables, but there is protein in there too. I think a really good guide to the whole phenomenon of going plant-based is the China study. So if you've never read that book, T. Colin Campbell, I think he still actually teaches at Cornell University. He's in his 90s. It would be a good read is the China study. It's also available in audiobook, which is how I listened to it about 8 years ago. Very valuable. and it explains exactly how the whole pathophysiology of eating animal protein, how that affects an organism like a human, or in the case where they did their research, rats, where they actually forced all rats in their research study to have liver cancer by exposing them to aflatoxin. So one group had, they both had liver cancer basically injected into them by aflatoxin. And then the one group they gave, normally they get 10% animal protein in their diet. The one group they forced to have 5%, so half the animal protein that they normally got. And they all lived longer and had smooth coats and didn't die of cancer. And then the ones that they doubled the animal protein from 10 to 20, they all died way before they should have, all with cancer. And so that's relating to cancer, but I mean, relating to just general wellness, you can look at it from a very similar standpoint. So it's called the China study. T. Colin Campbell's the author.
Again, a good book to listen to or read. Yeah.
Yes.
All right. Thank you so much, Dr. Blaskovich, for sharing a lot of your valuable knowledge and insight. I was amazed to see that you have so much knowledge and information in this field. I would suggest that you start, doing seminars around the country where you educate doctors, general practitioners, and other, even neurologists and neurosurgeons who are not aware. I would say, that would be definitely a wonderful way to share the knowledge that you have and maybe impact so many lives who are, suffering from this issue.
Absolutely. That's a good idea. Thank you.
All right. Thank you again, Dr. Sasha. It was a pleasure to speak to you, and hopefully we can get back in touch for maybe another session if the response is positive.
You're most welcome. Thank you. I would love that. Okay. Thank you.